Bueno, creo que el doctor Packer está online, ¿verdad? ¿Así, Marina? Así que vamos a dejar a uno de sus discípulos preferidos que presente su terapia de la Clínica Mayo. Son cosas bastante novedosas, pero que bueno, nos vienen a conocer. Gracias, Freddy.
Listo. No sé si Dr. Packer nos escucha. Can you hear us, Dr. Packer? Yes, excellent. Perfect. So I'll just introduce you in Spanish and then you can take over. Bueno, el Dr. Packer en realidad no necesita mayor introducción. Ha tenido una carrera de más de 3 décadas. Ha sido un investigador muy productivo y ha sido el presidente de la Sociedad Americana del Ritmo Cardíaco. Ha sido el director del Centro de Arritmias de la Clínica Mayo en Rochester. Él actualmente es un profesor principal de la Escuela de Medicina y dentro de sus múltiples actividades de investigación, pues recientemente ha hecho el estudio de ablación por catéter de fibrilación auricular, el estudio Cabana, que ha tenido una gran implicancia en cómo desarrollamos nuestra práctica clínica y sobre todo la intervención por catéter. Y recientemente ha tenido bastante interés en desarrollar estas terapias de haces de micropartículas de fotones y carbono. Y hoy día nos va a presentar exactamente acerca de esto, la particle therapy for treating un-ablateable substrate in device-resistant sudden cardiac death survivors. Dr. Packer, el auditorio pues queda a su disposición y gracias por tomar el tiempo de presentar hoy día. Yeah, so we're going to just go ahead with the recording and we're going to just connect again to answer some questions.
I'm Doug Packer, and I am very appreciative of the opportunity to be here with you in the Sudden Death Summit. I'd rather be in Argentina with you, but we are coming to you from Mayo, and I appreciate the invitation to be with you, and particularly to Luis, and wish you the best in your meeting. And for our part, we're going to talk about particle therapy and how you use it in patients who have refractory VT, and the device is not sufficient for dealing with it. So here are my disclosures. They're similar to what you've seen before. So we're going to talk first about the arrhythmia and then structural targeting. So when we're doing proton beam therapy or particle therapy, you first have to have an ECG. You have to have your source arrhythmia. That's going to tell you where you need to be electrically, but in a second, we're going to decide how you're going to get there structurally. You can use a 12-lead ECG, or you could use a 12-lead Holter. The problem is if you just interrogate the device, it doesn't give you enough information about where that VT is coming from. So this is our flow up to this point. You can use a map that you've created that tells you exactly where you've been and where you're trying to go. It gives you electrical source information. The ECGIs are also helpful in telling you the origin of the arrhythmia so that when we're doing what we're trying to do here, we know where is the source of the arrhythmia, and then we'll decide how we're going to link it up to the source of the structural abnormalities. We then go to that target contouring, and again, it's done with simulations as well. Now here we have a CT scan, and you can see going down the long axis to the apex. You can see that going from right to left, anterior to posterior. And you can also get a good idea of what that looks like when you're going down towards the apex to the point of the source of the arrhythmia that we're going to be going after and using the electrical information in conjunction with. Well, this is contouring. So we're drawing lines around the heart. This is an axial view. Yellow is the ventricle. Red is where the abnormalities are when we do MRs or when we do CT scans. We put that together, and then we contour, we do a simulation, and then we do treatment planning as you're looking with me at this workflow as to where you need to go. Now, once you've done that, you plan on how much dose to deliver in terms of particle therapy. Here's a dose volume histogram. So this is a dose that's needed to get a certain structural volume. We don't want to hit these are the organs at risk. We do want to be out here further, where we're closer to giving the site the source and dose that we need for it to be successful. So in a typical case of coronary artery disease, you have the myocardial scar, you've got normal tissue, and you've got 30 gray, which is what we usually use in proton beams. When you put that all together, they're all on top of each other, and we call that Venn consolidation. This is a Gaussian beam of the proton therapy. It's in the red and the black, and you can see that it goes out. It's very, very focused. And then suddenly it stops. The reason for that is this is done in a series of what are called Bragg peaks. And so you determine the depth by the amount of relative dose or energy that you're going to use. And then it drops off, and it drops off according to the Bethel-Bloch equation, which maybe is a little bit more complicated than we want to be, but this is the thing that tells you where you're going to go with your beam, and you already decided where you want it to be from the standpoint of the ECG information. And this is the beam. This is the beam firing off at the site that we want. It's about a 1 to 2 millimeter beam, and it goes all the way to that source of the electrical abnormality and the source of the structural abnormality or the scar. Here it is one more time, all the way down to the bottom of that diagram. So now in phase 1 of the proton beam study, what we've done is we've studied 5 patients. The black is how many arrhythmias they had before being beamed. The hatched is how many they had afterwards. And if you look at the average, it's 13 arrhythmias or ATPs or shocks before and 1.2 afterwards, after you've done your beam delivery. So let's look at the radiation effect. Here's the treatment plan. It's shooting one beam into that point in the ventricle where we need to be to get the arrhythmia that we desire to take out. If you look at PET scanning, you can see that the PET scan shows delivery right on the spot where you targeted. If you look after a radiation, then there are changes that occur in the kernel map and in the tissue itself. And then there's a progression of fibrosis. So now we need to talk about lesion formation. We're delivering a dose. We deliver it according to what the structure is that's abnormal and what the scar happens to be, and where we want to deliver a certain dose of energy. There's 4 weeks, 8 weeks, 12 weeks, and then the gross pathology you can see in the MR image, in the CT image, and here in the tissue pathology. That starts at about 4 weeks. The fibrosis increases at 8 to 12 to 16 weeks, and then it stays steady at that particular point. And if you look at the correlation between the volume on the MR and the volume in the lesion pathology, it's very, very good, very tight. Here again, we're looking at the dose that we delivered. Here are the lesions that were delivered. And then this is the scar. This is different parts of the myocardium. It's full thickness. You can look at E shown here. You can look at D, and then J or G and H show even more of the effect of what you've had in terms of fibrosis, edema, and caspase. So let's look at the time course further. If you look, we're trying to look at different kinds of protons deliveries, and we're trying to look at different particles, and we're trying to look at different components such as gamma H. And this is a biometric. If you were delivering 160 gray, you can see these are all splits in double-stranded DNA. You can see how much the peroxidase reaction has changed compared to the controls. If you look here with caspase, caspase tells you about apoptosis. It actually occurs fairly early. It's active early on. You can see it here. You can see some a little bit later and going from 12 to 40 weeks. but it mostly comes in the 10 to 12 week time frame. And if you look at the lesions, then those lesions are increasing in size in terms of fibrosis according to how much you've delivered in terms of 30 or 40 gray. If you look at the irradiation effect on bipolar voltage, here's normal tissue with 40 gray. After you deliver that, you get the pink. The normal tissue starts to decrease in terms of the bipolar voltage. Would be the same if you did a voltage map. Here's an infarct star, and it drops off even more. So the bipoles decrease substantially. Well, let's look at conduction velocity. Here's baseline, here's our planning CT. Here you can see the infarct star that we created. Here you can see the delivery of 40 gray, and you can see where each component is. This is, again, infarct scar, 40 gray, and normal tissue. And we do it by triangulating. You can see here that actually what happens is that in looking at this, the conduction velocity actually increases. It doesn't decrease. You can see the fiber orientation there, transverse and longitudinal, but these are compared before and after, and the thing that you see is that the conduction velocity increases in some images, but for the most part in our work, the conduction velocity decreases. And the reason why it does that is because of the fibrosis. So we'll give you that there could be a little bit of an increment, a little bit of an increase, but in most studies, it shows that that's not consistent. And in pig hearts, it certainly is not. So you get a conduction velocity that drops. You also look at connexins, and the connexins drop in normal tissue, or they drop down with irradiation. So we've got a drop in our bipolar voltage. We've got a drop in conduction velocity. We've got a drop in caspase, or an increase in caspase, and we've got a drop that occurs in the connexin 43. So all of those suggest that there's an increasing effect, starts fairly early, but there can be a little bit of a change in conduction velocity in the other direction, but not typically. Well, I appreciate talking with you. This is the team that's been working with us. These are the folks from Mayo, the folks from Mayo Radiation Oncology, the GSI Helmholtz Centrum in Darmstadt, that's kind of like Los Alamos, and in the Heidelberg Ion Center Therapy, and at CERN with Ugo Amaldi and Giovanni Leo. So this is the team, this is the outcome, to take care of those cases where, unfortunately, your effort with the either ablation or your effort with a device is not good enough, and you have to go to particle therapy. A lot beforehand, very little below afterwards, and so it's been very, very effective. And we think that it's going to be even more so as we learn more about it. Well, there are a lot of particle therapy centers in the US. I don't have a map of Latin America or South America where you are, but I hope this gives you kind of an idea of what we do with particle therapy, what the flow is like, and how it works both from the standpoint of the electrical sourcing and the ventricular sourcing. So I appreciate being here. Thank you so much for the invitation, and we wish you the very, very best for the rest of the meeting.
Excelente. So, tenemos al doctor Guillermo Mazzo y al doctor Carlos Labadet en el panel. You want to go ahead, some questions?
Okay, thank you. Muchas gracias. ¿Haces la traducción? Bueno, la verdad que es súper interesante este método. La verdad que creo que se correlaciona con lo que vimos en la charla anterior. La verdad que está muy bueno poder llegar a algunos lugares que no podríamos llegar normalmente con una catéter y viendo bien las zonas. Lo que a mí me da un poquito de miedo es, cuando lo pienso, es cómo logran no generar más daño en un corazón que está en movimiento. No digo, se está moviendo y no es lo mismo que esté estático que esté en movimiento. Nosotros vemos la imagen estática, pero esto se está moviendo. Y la verdad que yo leí algunos trabajos que presentó el doctor y la verdad que me parece súper interesante, ¿no? Pero bueno, eso es lo único que me preocupa.
So I think, the question would be, I mean, amazing technology, very promising, but how do you compensate for the potential error that induces, movement, respiratory movement, cardiac cycle? And to add to that question would be, how precise is this method?
That's a very, very good question, Freddy. First, we gate according to respiratory phase and cycle. During end expiration is when you deliver the beam. During inspiration, you don't deliver the beam. We have developed several scanning approaches to help us with looking at cardiac motion. Now, with the cardiac motion, that can be gated, something we're working on with ultrasound. It can also be gated in its relationship to the breathing pattern. It turns out that the precision of the beam is 1 to 2 millimeters. And so if you've got a pretty good idea from the MR and from the CT and from whatever your map was before they had their recurrence, it turns out that cardiac motion is not that great. It's not so much that it would destroy the approach. But we are working on 2 or 3 things, and I'll just say this. You have to gate to QRS complex, but then you deliver during the cycle after that complex. And in doing that, it takes care of the motion to a great degree. So that's a good question.
Yes.
Bueno, gracias por la charla realmente excelente y de algo tan novedoso y de avanzada. Bueno, yo soy electrofisiólogo, pero yo quería preguntar el grado de reproducibilidad de estos tratamientos y la curva de aprendizaje, si es la misma, digamos, están viendo que los resultados se reproducen en los distintos grupos, y si la curva de aprendizaje, ¿cómo es? ¿Es fácil? ¿Es muy difícil? ¿Cómo ven en el futuro la difusión de esta técnica?
Sure. So the question would be, we are electrophysiologists, and we're not familiar with this type of radiation therapy. But how do you see this in the future? I mean, is there a learning curve that the electrophysiologists will need to look after, to learn this technology? And you will always be dependent on people who have, physicists and people from radiation oncology to do these therapies?
So again, that's a very important question. So if you look at this, you need EP physicians. But see, they already know how to do ICDs. They already know how to do mapping. From the last talk, you saw how learned from MRs and CTs about fibrosis and scarring. So you either have a heart failure person look at that, but in my experience, most EP docs have a very good idea about the structure and where scar is. And they can take a heart and they can look at that scar, and they can also look at where the ECG should go. So yes, there's a learning phase in looking at the ECG and registering it to the morphology of the heart. And then he's exactly right. When you deliver it, the radiation therapy docs need to do that. But the EP docs, we're the ones that tell them where to shoot. So if you can identify where something is coming from electrically, even if it's just looking at an EKG, and if you can identify the scar, again, as per the last talk, then you can tell them where it needs to be delivered, and then they can do it. So while it seems complicated, and while there is a learning curve, at the end of the day, it's quite as hard as what you might think of to begin with. And I think it's worth it because then you don't have to use a bunch of catheters.
Sounds great. Go ahead, Luis.
Dr. Parker, Luis Aguinagas speaking. Good to see you.
Good to see you. Good to talk with you. Thank you.
I would like to congratulate you for this wonderful presentation. I would like to mention that, and thank you again, because you are taking part in all our meetings every year, and maybe next time you could be present here in person in our meeting. Thank you so much. And my first question is, what could be the effect of proton energy in the ejection fraction? I understand that all of these patients were ischemic patients with scar pathology.
So, again, really good questions. With protons, since you can guide them and stop them, you don't have to worry as much about damaging the esophagus, damaging the phrenic nerve, damaging the pulmonary veins, damaging other things. The number one most important issue that you have to know and be sure that you're not delivering in residual healthy myocardium. That's the key. So if, let's say you have an ejection fraction of 10 or 15%, you can't afford to take out a lot more than that. If you've only got 10 to 15%, you have to make sure that you're only delivering where the scar is, and you have to leave the other tissue that remains healthy alone. So we recommend that you don't try to do anybody with an ejection fraction less than, say, 25%. And then you have to make sure that your beam is directed away from residual myocardium at risk. That would be the biggest problem. So, Luis, I again appreciate being with you, and next year I'll be there, and we'll look forward to that. But you've kind of hit the major point. You can't afford to destroy much residual normal myocardium, because then you have an ejection fraction of 5%, that patient's not going to die. That's happened with photon therapy, but we've not seen that happen with protons because of how the beam works.
And the last, sorry, Freddy, and the last question is if this therapy has been proved in another etiologies, scar in not ischemic scars.
So in the work that we have done, animals, we create infarctions. And so most of the deliveries have been in infarcted myocardium. Clinically, we've done it in patients who have non-ischemic myocardial abnormalities. It can be done in someone with sarcoidosis. The only thing you have to do with sarcoid is you have to have a PET scan that tells you where the problems are. But the answer to your question is it's a lot easier to do an ischemic. It's not that hard to do a non-ischemic. You just have to be more careful at your delivery.
And thank you. And maybe as a suggestion, next time you can include Tucumán or Argentina in your map of centers with proton energy. Thank you so much.
Very good.
Dr. Parker, thank you so much for your presentation. Thank you.
Thank you. Thank you. Sounds great.